This is Ms. Rollerson, and we are going to start part 2 of medication administration. And it starts in your Davis textbook on page 805. In today's lecture, we're going to learn about the parenteral routes of delivering medication. That would be anything that goes into the vein or into the tissue or into the muscle. So that will include your IM injections, your subcutaneous injections, your intradermal injections, and your intravenous injections. When you think parenteral, you need to think injection or infusion into the body. Medications that are given, when given medication, the parenteral route, you need to make sure that you're choosing the right equipment. So first we're going to look at the needles. So needles, we look at two different measurements. We're going to look at the gauge and we're going to look at the length. Now the gauge is how big circularly is in diameter is the lumen of the needle. So sizes range anywhere from 14 to 30. And you want to choose the gauge depending on the patient size, the type of medicine you're giving, how thick it is, and then how often you're going to have to give this medication. You want to use the smallest gauge needle possible for comfort of the patient. The smaller the gauge, the larger the number. So in other words, 30 is the smallest gauge and 14 is the largest gauge. So if you're going to give somebody something very thick, you may need a 14, 16, or 18 gauge needle to give a medication that's thicker. If the medication is thinner and you're giving that medication frequently, such as insulin, you could use a smaller gauge, 25 to 30 gauge needle. So then you're going to look at length. Okay, length ranges anywhere from 3/8 of an inch to 3 inches long. So this, when choosing your needle, you're going to look at the size of your patient, the size of the muscle or adipose tissue you're going to go into, and the site of the injection. So are you giving it intramuscularly? Are you giving it subcutaneously? Are you giving intradermally? That will help you determine how long that needle needs to be. So for example, if you have a patient who weighs 300 pounds and you need to get to muscle, your needle may be longer to actually get through the subcutaneous tissue into the muscle. If you have a little lady that's 95 pounds and you're going to give a subcutaneous injection, you're going to need a shorter needle to get into the subcutaneous tissue without hitting the muscle. In choosing a needle, you need to decide, do I need a needle that has a filter on it? And do I have needles that have a safety cap on them, which is the best case scenario to prevent accidental sticks. So the filter, if you look to the right, you see several different types of vials that we will draw medicine out of. On the left of that picture, you see your ampules, and these are glass ampules, and you will pop that lid off of them. So that little glass may actually fall into the medication. So when you draw up this medication, you want to use a filter, a needle with a filter on it, to keep you from drawing up that glass into your medication. And then on the right side of this picture are your vials, and you have anywhere from plastic vials to glass vials. And at the top of these vials, you'll have a little rubber stopper, and your needle will go into that rubber stopper to draw your medications out. If you look at the picture down on the left at the bottom, you see a safety needle. This is where you can actually, once you give the injection, you can flip that little pink cover over the needle so that you don't accidentally stick yourself or the patient or someone else while delivering that to a biohazard bin. So we've chosen our needle. Now we need to choose our syringe. So there are different size syringes. If you see the picture to the right, you see a 3 milliliter, a 5 milliliter, and a 10 milliliter syringe. And then at the bottom on the left, you see a tuberculin syringe. This is a smaller syringe. It's only 1 milliliters, and we can actually draw up tiny dosages of medication using this syringe. So you see this syringe used in children so that you can get precise dosages. In TB tests or allergy tests, you see these syringes. Or any potentially dangerous medication, we will use one of these syringes. Potentially dangerous would be your heparin, which is a blood thinner and anticoagulating medication. You want to make sure that you're drawing up exact dosages. Okay, so you're going to use a specific syringe to give insulin. If you look at the picture on the left here with the orange cap, that is an insulin syringe. Insulin is calibrated in units, so anytime you give insulin, you're going to say, I'm giving 1 unit, I'm giving 20 units, I'm giving 30 units, so it's specifically in units. So this is the syringe you're going to use because it's calibrated in units. This particular syringe you can give large amounts of insulin in, because you see it's calibrated in 10 units, 20 units, 30 units, all the way up to 100 units you can give using this syringe. And then there are some smaller syringes where you can give 1 unit, you can give 2 units, so you can give smaller doses. They'll be calibrated for smaller dosages. The needle on an insulin syringe is usually a smaller gauge needle, 26 to 30 gauge needle, because these people who have diabetes are giving themselves insulin, up to 5 times a day. So the smaller the gauge needle, the better. And then they're going to want to rotate the site that they give those injections. Okay, so then on the right side, you have a picture of a reusable cartridge holder. And then you would have pre-filled cartridges with the medication in them. You would put that into the cartridge holder and you would give your injection using that cartridge holder. Intradermal injections are given directly into the dermis, which is your skin. That epidermis layer, you're going to give the injection in that epidermis layer. Medications that are typically given intradermally are your TB test, tuberculosis, or your allergy testing. And the TB test is typically given in the forearm, and the allergy test can be done in the forearm or in the chest and the arm. And if you look at the picture to the right, you can see this young man has had allergy testing, and you can see he's positive for certain allergies because he has big red whelps. The ones where you see the smaller red areas are negative, but the larger red areas would be positive for that allergy. You're going to need a smaller size syringe. It's going to be less than a milliliter. And then your gauge needle is going to be smaller to 26 to 28 gauge, because you're going to give very tiny 0.1 milliliters of medication up underneath that dermal layer. Subcutaneous injections are injected into the layer of fat between the dermis and the muscle. It is a slower absorption than if I were to give it into the muscle, because there is not as much of a blood supply to the subcutaneous tissue as there is in a muscle. If you give the injection in the abdomen or in the arms, the injection absorbs faster than it would in the legs or in the rear buttocks. When you give a subcutaneous injection, because there is very little blood supply, you don't have to aspirate. And what that means is when we give an IM injection, we're going to aspirate, where we actually pull back on the syringe to make sure we're not in a blood vessel. You don't have to do that with subcutaneous injections. And then when you give it in the abdomen, you want to make sure you're at least 5 centimeters from the belly button, umbilicus, and that's about two inches from the belly button. You're going to want to rotate the site at least 2 centimeters apart, so that's about 1 inch apart. So someone that's giving insulin 4 or 5 times a day, they do not want to give it in the same spot every time. They want to move about 2 centimeters from the previous spot to give that insulin. If not, that fatty tissue is going to become hardened, and then medication will not absorb as well after it becomes hardened. When giving a subcutaneous injection, so you're going to look at your needle length first. How long does this needle need to be? The bigger your patient, the longer the needle. The smaller your patient, the shorter their needle. What gauge? You want it to be as small as possible to be comfortable for the patient, but you also want to make sure that the medication you're giving is not too thick to go through a smaller gauge. So the thicker the medicine, the bigger the gauge, that you want to use the smallest gauge possible. So normally you're going to use a 25 to a 30 gauge needle to give a subcutaneous injection. So when you give an injection, do you give it at a 45-degree angle or do you give it at a 90-degree angle? So if you look at the picture to the right there, you can see that you can give this injection straight down or you can give it at a 95-degree angle. So if your patient is smaller and doesn't have a lot of subcutaneous tissue, you're going to want to give it at a 95-degree angle so that you don't hit the muscle. And then if it's a larger patient, you can give at a 90-degree angle, which is an easier way to give the injection and usually more comfortable way to give the injection. The administration of insulin requires that specific insulin syringe to administer. Remember, insulin is given in units, not milliliters. All other medicines are given in an injection form are milliliters, but insulin is given in units. When you give insulin, you may have a routine dose where the doctor says give 6 units of NPH insulin every morning. Or you may have a sliding scale. What the sliding scale means is you base how much insulin you're going to give your patient based off of what their blood sugar is that morning. So you'll have a range that says if the blood sugar is between 100 and 140, give no insulin. If the blood sugar is between 140 to 200, give 1 unit. If it's between 200 and 250, give 2 units. And so on. So you will look at that sliding scale to determine exactly how much insulin you're going to give. Insulin, you may be using a disposable syringe, like I showed you in the previous picture with the orange top to it. You may use an auto injector or an insulin pen to give the medication, and this is a device, and we'll show you in lab, that you put a needle on top. You screw a needle on it, and then you turn the end of the pen to calibrate how much insulin you're going to give. So you would turn 1 little click to get 1 unit, 2 clicks to get 2 units, 3 clicks to get 3 units, and so forth. Your patient may have an insulin pump. This is a device that the patient will wear for, it's usually a 3-day period that they wear an insulin pump for at a time. With the whole needle set up and everything, they would have a needle that is injected into one of the subcutaneous sites. The needle's removed, the catheter sits there, and it's hooked up to an insulin pump, and that insulin pump delivers insulin throughout the day at different intervals as needed for your patient. And then every 3 days they will change that injection site to a different site. Okay, so on the right side here you see the categories of insulin. You have what's called your basal insulin, which is the insulin that you give yourself in the morning, and it lasts either until the afternoon or it lasts all day. So they're usually good for 12 to 24 hours. So you give yourself 1 dose of insulin and it lasts all day. And then you have your prandial insulin, which is given at mealtime. So it's kind of like a bolus of insulin. You give it, it works very quickly, and then it goes away. And those, you give your prandial at mealtime. So that's your regular insulin, your insulin Lispro, your insulin Asport, and your insulin Glucagon. So those are insulins that the patient would determine how much they're going to eat for lunch. They would count the amount of carbs that they're going to eat for lunch, and they will give themselves a set amount of insulin to take care of those carbs that they're getting ready to eat. And then you have some insulins that are a combination of the fast-acting and the long-acting insulins. Now, next semester, when we talk about insulin and diabetes in more detail, we'll talk about these medications in more detail. But what we need to know right now is that you can mix their basal dose of insulin with their prandial dose of insulin into one syringe, and you can give it together. Now, there is a very specific way to do this. You have to mix them in the right order. So when you look at your basal insulin, let's look specifically at NPH. NPH is a cloudy insulin. When you look at it, it's going to be cloudy looking. And then your prandial, your regular insulin, is going to be a clear insulin. So when you mix these, you have to mix them a certain way because you don't want to mix the cloudy into the clear. You don't want to make the clear go cloudy. So you always mix them in a specific order. And we will do this in lab, and we'll talk about it more in lab. But I'm going to just go through real quickly the order that you're going to do these things in. So the first thing you do is you have your two insulins. You determine the dose that you're going to give of each insulin. You're going to take the NPH insulin, which is the cloudy one, and you want to roll it between your palms to mix it really well. You don't ever want to shake it vigorously. You just want to take it and roll it in your palms to mix it well. Then you're going to take an alcohol swab and clean both of the lids to both of the insulin vials. You're going to inject air into your NPH insulin first. Then you're going to inject air into the regular insulin. And while you're in the regular insulin, you're going to go ahead and draw that regular insulin up, because you always draw up the clear first. So you draw up how many units of regular insulin you need. And then you're going to take your syringe into the NPH insulin, which is that basal, which is cloudy. And then you're going to draw up how much of that you need. So that is a specific order, and that's something that we need to learn, and we'll learn that in lab. Your NPH, like I said, is the cloudy one, and we want it to be cloudy. The regular insulin should not be cloudy. If it is cloudy, you need to discard that insulin and get a new bottle. Heparin and enoxaparin are two very common drugs given in the hospital. They interrupt the blood clotting formation, and so any patient that you have that is at high risk for blood clots may be on this medication. This medication is given subcutaneous, and the dosage that you give is based on the patient's weight and their anticoagulation studies or coagulation studies. And those levels would be looking at your PT, your PTT, your INR, your platelet count, your bleeding time. So they're going to look at those studies and determine how much your patient should be on. Also, your patient's risk. Are they on bed rest? Did they just have surgery, so they're going to be in the bed more than usual? They're at a higher risk for blood clot development. With these medications, you're going to use the smallest gauge needle possible because when you're giving this medication, it does increase the risk for bleeding. So you're going to use a smaller gauge, 25 to 26 gauge, and the needle will probably be the shortest needle, depending on the patient's size, of course. You're going to use a 1 milliliter syringe because you want this medication needs to be very accurate in its dosage. You're going to give it in the abdomen. It needs to be at least 5 centimeters away from the umbilicus. You're going to rotate the site with every injection at least 2 centimeters away from each other. You're going to make sure you draw up the exact correct dose, and then you're going to add 0.2 milliliters of air to the syringe. You'll pinch the skin between the thumb and the forefinger, and you will insert the needle at a 90 or 45-degree angle, depending on the size of adipose tissue. You do not want to massage the area after you're given, and then when you give it, after you give it, you need to document the site that you gave it in. Intramuscular or IM injections. So this is where you're going to give the injection into the muscle, It absorbs faster than a subcutaneous injection because there is a larger blood supply. You can administer up to 5 milliliters in a large muscle. Now this is what your book says, but I can tell you that I've never given 5 milliliters IM injection before. To choose your site, you're going to decide from 3 different sites, and we'll talk about those sites in a little bit, but you want to make sure that the site that you give the injection is safe from nerves, from large blood vessels, and from bone. You want to make sure it's free of tenderness, there's no skin breakdown, no necrosis at the site, and then you're going to want to make sure that the muscle is large enough to accommodate the volume of medicine that you're going to put in it. So if you have to choose between the deltoid, which is your upper arm, or your vastus lateralis, which is your leg muscle, you're going to want to choose the leg muscle if you have a larger amount of milliliters to inject, and you're going to want to choose the deltoid if you have a smaller amount. So to minimize the pain during an injection, you're going to want to make sure that that muscle that you're going to inject in is relaxed. So for example, if you're going to give it in the vastus lateralis, which is in the thigh muscle, you're going to want them to either sit down and relax their legs or lie down and relax their legs. You're going to want to give it in a Z-track method. The Z-track method is where you take the skin and you displace it about an inch and a half. You're going to pull it to one side. You give your injection and then you let go of that skin, and then that causes, which I'll show you a picture of that later too, it keeps the medicine in the muscle and keeps it from going back up into the subcutaneous tissue, causing some irritation. You want to inject at a 90 degree, and then when you remove, you want to remove at the same angle that you injected. Inject the medicine slowly and not extremely slow, but if you inject it very fast, it's going to cause more pain than if you were to inject it a little slower. If you distract the patient, I usually have the patient take a good deep breath and then blow it out, and as they're blowing it out, those muscles relax. After the injection, you're going to want to apply gentle pressure to the site. You don't want to massage the site, which can cause irritation. You want to acknowledge it's going to pinch a little bit or it's going to hurt a little bit, and then you can cool the area with a cool cloth or ice, but some medications you're not going to want to do that, so you need to be careful with that protocol. When giving an intramuscular injection, you're going to want to look at the needle length. The length is usually going to be between 1 and 3 inches. Standard size is 1.5 inches. You're going to look at the size of the muscle and the amount of adipose tissue to decide what length you're going to use. So the bigger your patient, the longer the needle. And then you're going to look at gauge. Gauge is determined by the thickness of the medication you're given. So the thicker the medication, the larger the gauge, which would be a 20 gauge. The thinner the liquid, the smaller the gauge, which would be to 25 gauges. You're going to always give the injection at a 90 degree angle. And then when you're given an IM injection, you're going to use the Z-track method. This is where you take, and if you look at the picture below, you can see the person has taken their finger, they're pulling the skin, they're giving the injection at a 90 degree, and then when they let go of the skin displaces, moves, and it locks the medication in the muscle so that the medication can't come back up into the subcutaneous tissue. This is recommended for all IM injections, and there are some videos on this slide going over IM injections. Comfort and safety when administering parenteral medication is extremely important. There's several things that I've already mentioned, but I'll mention them all again here. Things that can promote comfort and safety for your patients. Number one is using aseptic/sterile technique to minimize the risk of infection. So when we're giving injections, we're cleaning the site and we're making sure that the equipment that we're using is staying sterile while we're giving that injection. We're going to use the smallest needle possible to decrease comfort. We're going to choose our site based on the volume of the medicine and the viscosity of the medicine. Large volumes of medicine into a small muscle can cause pain and tissue damage, so we're going to want to make sure we choose the right size muscle for the medicine. If the medication gets in the wrong tissue, it can cause damage, so we're going to make sure we give our IM injections IM. We're going to make sure we give our sub-Q injections sub-Q. We're going to dilute the medication as advised by the manufacturer. We're going to use the Z-Track method, which is displacing that skin, and we're going to make sure that we use the correct sites. There are 3 sites to give, approved sites. Actually, there's 4. There's 4 approved sites to give IM injections, and the reason they're approved sites is because the risk of bone injury and nerve injury is lessened because there's less nerve and bone in the area we're giving the injection, and also there's less large blood vessels in those areas, so that decreases our risk of injury for our patient. When giving an intramuscular injection, there are 4 sites that you can give the injection into. There's your ventrogluteal muscle, your deltoid, your vastus lateralis, and your rectus femoris. So let's talk about each one of those sites. So the first picture you see is the ventrogluteal site. This is the preferred site for an injection, but not always the most realistic site. So it will depend on what type of injection you're given. It's located away from any major blood vessels or nerves. It involves the gluteus medius and the gluteus minimus. It feels hard when you palpate it, but it's because there's little subcutaneous tissue in that area. There's actually lots of muscle. It's when we show on the skeleton, when we get in the lab, I'll show you on the skeleton, it's actually in the cup of the hip bone where you're going to give the injection. You're less likely to hit bone than any other site, and it's important to have the patient relax the muscle. So they're going to lie on their side to give this injection. The deltoid muscle is in the upper arm. It's easily accessible, so if you're going to give an injection that just requires 0.5 milliliters or 1 milliliter max is what you would give in the deltoid. This is where you would give those sites. This is where most vaccinations are suggested to be given. That muscle's not always well developed, especially in your elderly adults. So that could be one negative. You don't want to use it in an infant unless there's reason why you can't give it elsewhere. It is small, and it is close to the radial and brachial nerves, so you do want to make sure you're giving it in the exact right spot. And like I said, it's preferred for vaccine and flu shots. The vastus lateralis, if you'll look at the picture to the right at the bottom, that is where you give the rectus femoris and the vastus lateralis. So the vastus lateralis is preferred site among infants. There are no large blood vessels or nerves. Drugs, medication can absorb rapidly in this area because you're going to be moving and walking after you get the injection. It accommodates for a large volume of medication. It's very convenient for self-administration. The disadvantages is that the patient can see you giving the medication, which may increase their anxiety, and there is an increased risk for soreness because you're going to be using that muscle more frequently than you would other muscles. Then you have your rectus femoris, which is the middle of the thigh, and we'll show you how to find all of these sites when we get to the lab. But the rectus femoris is no longer recommended in children. We do use it in adults only when there's no other site accessible. It is easily accessible for self-injection, but this site is usually the most painful site. I have added a couple of YouTube videos where you can actually see the injection site being found. Intravenous. So intravenous is where the medication is injected directly into a vein. You insert a catheter into a vein and leave that catheter in there for a certain period of time so that you can give medication as needed through that catheter. Of course, when you insert an IV, you use a needle to insert it. You take the needle out and leave the catheter sitting in the vein. The good thing about an IV is it gives you instant medication and instant reaction to that medication. It does not have to be absorbed into the bloodstream. It's being injected into the bloodstream. The onset of the medication is within seconds. I don't know if any of you have ever been put into sleep by using propofol, but propofol is a white milky medication, and you can actually see it when it actually starts hitting the vein. Within 10 seconds, your patient is going to sleep. However, that quick, immediate action can be negative. If your patient has an adverse reaction, it can happen very quickly, and unless there's an antidote to that medicine, it's hard to reverse that because it's directly into the bloodstream already. When inserting an IV, you first have to choose your IV catheter size. So you choose that based off of what's going on with your patient and why your patient needs an IV in the first place. If your patient has an infection and they need to have an IV infusion of antibiotics, that is a thin antibiotic, you can put a smaller gauge needle in. It's less painful. But if your medication that you're going to be given is thicker viscosity, you're going to want to use a larger gauge needle. Or if your patient needs blood, you need an 18 gauge to transfuse without damaging cells. So you're going to want to decide, what's going on with your patient, and could there be a potential for an emergency situation, and choose your gauge based off of your patient. When infusing intravenous medication, there's 3 different ways you're going to give it. You're either going to give it IV push, IV piggyback, or you're going to have the medication just dripping over a long period of time. So let's talk first about IV push. IV push is where you have a dose of medication and you're going to give it over a very short period of time. You're going to want to make sure you're using aseptic and sterile technique. You clean the ports before you give the medication with an alcohol swab. You make sure that your needle that you're using is sterilized and it's not contaminated in any way by accidentally touching the table with the needle. If you ever do that, you're going to want to get a new needle and start over. You're going to want to make sure that you have an antidote on hand. So an example of that is if I give an opioid. When I worked in the GI lab and we did colonoscopies, we would put the patient to sleep with Versed and fentanyl. Well, the antidote to Versed and fentanyl is a medication called Narcan. So anytime we were given those 2 medicines, we would always have Narcan available just in case we needed to give it to reverse the effects of the medication. Because medication in an IV is directly into the system, it's going to have an immediate effect. Many drugs can be given IV push, but you need to make sure that you read the guidelines of the manufacturer's guidelines on how fast you can give the drug and if the drug needs to be diluted with anything. And if you're diluting it with something, for example, water or saline, you're going to want to make sure that you know exactly what to dilute it with, because some things will break down if you mix it with water and some things will break down if you mix it with saline. So you need to make sure you mix it with the right dilutant and that you give it over the right amount of time. So usually the order will say give 5 milliliters over 1 minute or give 5 milliliters over 5 minutes. So you're going to want to make sure that you know the medicine that you're given, if it needs to be diluted, and how quickly you can give it. Because when you give it rapidly, you can't take it back. But if you give it slowly and your patient starts to have a reaction, then you can stop the IV push without giving the full dose. Some medicines can be very, very dangerous if given IV push, and I mentioned earlier about how a coworker of mine had accidentally given potassium IV push. Well, that's a medicine you never give IV push. It has to be mixed with a very large amount of saline, and it has to be given over a very long period of time. So it's not something you can give very quickly. Okay, so that was IV push, and then you have IV piggyback. So what this means is you have a liter of normal saline hanging, and it's dripping into the patient's veins very slowly over an 8 to 12 hour period, however quickly you want it to go in. And then you have another medication that you're going to add, and so you're going to have a small bag, maybe a 50 milliliter or 250 milliliter bag that has that medicine in it. For example, an antibiotic is very common to piggyback. So you're going to take that smaller bag, you're going to piggyback it into the larger bag through the IV tubing, and you're going to have it infuse over a certain period of time, maybe 30 minutes to an hour. That smaller bag will infuse. If there are no fluids infusing at all, the patient's going to have what we call a saline lock or an IV lock. That's where you would have it shut off completely. They're not getting any fluids, but if you want to give an antibiotic every 8 hours, you would go in and you would hang that bottle or that bag of antibiotics. It would infuse over a 30-minute to an hour period, depending on the guidelines from the manufacturer. And then after you do that, you would flush it with saline and close it off again. And then you have medication drips. This is where you constantly have a drip of medication. It may be ordered to keep the vein open, which is a very slow rate of infusion, or it may be that you're given 100 milliliters in an hour. But you usually put this medication on a pump, and you set the pump to run at 100 milliliters an hour. There are certain medications such as potassium, blood pressure medications, cardiac medications, heparin, insulin, oxytocin that's given to increase the onset of labor. These things, there's certain drugs that must be on a pump. You can't just let them hang. And the drugs are usually pre-mixed by the pharmacy, but there are still some nursing units that have to mix their own drugs. So when you're mixing those own drugs, you need to make sure that you're following the manufacturer's instructions for mixing those drugs. I borrowed the next two slides from a lecture that we'll get in a few weeks, but I just wanted to give you some pictures of peripheral vascular access, and you can see the two catheters at the top. You have one catheter that's in the over the needle catheters, and you have an inside the needle catheters. So most of them are the ones at the top, which is that over the needle catheter. So once you get the needle into the vein, then you would thread the catheter into the vein. The picture at the top to the right is what we call a butterfly needle. These are usually shorter, more beveled needles. And a lot of your nurses that are really good at putting IVs in will want to use these butterfly needles. It's just a preference over the regular needle catheters. The bottom to the left is just a picture of an IV site with the tubing coming from it. And it looks like this is a continuous IV because the tubing continues. And then this last picture, the right bottom picture, is a picture of when I told you you could have the IV shut off in between uses. This is the tip that you would put on it to lock it when you don't need to use it. So I also borrowed this slide from a future lecture, but I wanted you to take a look at the central venous access devices. If you remember a few weeks ago, we did dressings over a central venous access device, and you saw how important it was to keep this area free of infection. And the reason being is because it is directly inserted into a central vein. Your central veins are bigger, closer to the heart than your peripheral veins are. Okay, so first I want to look at the picture at the bottom in the middle. That's a PICC line. It is a peripherally inserted central catheter that's inserted into a peripheral vein. But then if you look to the picture to the left, it shows how that peripheral vein, the catheter, is actually threaded up into the superior vena cava. So it sits right in the chamber just before it goes into the heart. And then you look at the picture at the top left, you see a central line that's inserted into the vena cava and threaded into the superior vena cava. And the same, the picture on the right bottom is actually a port that is inserted underneath the skin. The catheter is threaded underneath the skin into the jugular vein and then threaded down, and it sits in the superior vena cava also. And then that way this medication, this port, can stay there for a long period of time, and it's for patients who need frequent access, maybe a patient who is being given chemotherapy over a long period of time. And they can go in, it can be accessed, and then it can be shut off and closed off so that when they leave, they don't have a port that can get easily infected. So you would want a central line when you have a medication that's going to be irritating to the artery, to the vein, or very thick, very viscous medication. So antibiotics, parenteral nutrition, chemotherapy are examples of things you would want to give through a central line. And this is just a picture of your central venous access device from the outside so that you can see it has several different ports. You can draw blood from those ports. You can give medications through those ports. You can give fluids through those ports. When giving medication parenterally, you first start with drawing up the medication. As I mentioned earlier, there are ampules and there are vials. So your ampules are usually glass, and they're usually 1-dose containers. You have to snap that lid off, and you have to use a filtered needle to make sure you don't pull up any glass out of those vials. Then you have your regular vials that could be glass, they could be plastic. They're usually, they can be single dose vials or they can be multi-dose vials, meaning you can get several dosages out of one vial. You're going to have to remove the metal top to start with, and then you have a rubber stopper that seals the medication in. When drawing medication out of a vial with a rubber stopper, you have to first inject the amount of air that you want to pull out. So if you're going to pull out 1 milliliter of medication, you have to inject 1 milliliter of air first. But you have to rub that stopper real good with alcohol swab before you inject the needle into it. Typically, I would use 2 needles. You use 1 needle to draw the medicine up, and then you change the needle out before you give the injection. Change the needle out, push all the air out before you actually give the injection. That way, you don't have a reaction due to the rubber stopper. Some people are allergic to that rubber stopper. If they're allergic to latex, they may also be allergic to that rubber stopper, so you want to change it for that purpose, and you also want to change it because you may have dulled your needle by sticking it through that rubber stopper. Okay, so then also there's some medications that may come in powder form. They are unstable once they are mixed with a solution. So they come in powder form, and you have to actually dilute the powder yourself before you draw the medicine up. So you dilute it, you roll it in your hands, to get it mixed. Then you either mix it with saline or sterile water, but you have to look at the manufacturer's package to determine what you're going to mix it with. And then you will draw the medication up into your syringe after mixing it. You can mix 2 medications in the same syringe. An example of that, and this is an old example, but Demerol and Phenergan go well together. They actually work well together. They increase I'm trying to look for the right word. They enhance each other's ability to work. And they also are compatible when you put them together. So those 2 medicines you could draw up and just give 1 injection versus giving 2 separate injections. But before you mix 2 medicines together, you want to make sure they are compatible. You want to make sure that the total dose is acceptable for where you're going to give the injection. And you want to make sure they can both be given the same route. So you wouldn't want to give one medicine that's supposed to be given IM and one that's supposed to be given sub-Q together. And you want to make sure it's not more than, if you're going to get it in the deltoid, you can only give up to 1 milliliter there. So you would want to make sure that it is not above 1 milliliter total solution. So for safety purposes, you're going to want to use a Sharps container. When you are finished giving an injection, everything that is sharp needs to go into that Sharps container. That is a puncture-proof container, usually red, with a biohazard symbol on it. You want to always avoid recapping a dirty needle. So once you've given your injection, you never put the cap back on that needle. Now in the lab, when we're practicing, we have to use those needles over and over again, and they have not been used on a real person. So you will see us putting the cap back on, but we'll show you the appropriate way to do it so you don't accidentally stick yourself. But in the real world, you never recap a dirty needle. That is a way to end up sticking yourself, and then you have to go to employee health and be tested for certain diseases that are bloodborne. It's best to use a needleless system. A lot of the IVs have adapters that are needleless, so that's the best case scenario. And using needles that you have a safety cap on them when you get done, so that you can just push that safety cap over the needle to keep you from sticking yourself or someone else. When giving parenteral medication, you want to make sure you give it in the correct site, which I know we've said this already, but the wrong site could mean that you've given a sub-Q injection IM or an IM injection sub-Q. So make sure you're giving it the right site, and make sure that you are familiar with techniques for heparin, insulin, because they're a little bit different than your typical subcutaneous injections. When administering a drug via parenteral route, the drug would be absorbed the fastest if given per intramuscular route. Is this true or false? So the answer is false. Absorption refers to the movement of the drug into the bloodstream. And so therefore IV, which is also considered a parenteral route, would be the most instant, the fastest way to get a medication to absorb. Okay, so this is the completion of day 2 of medication administration lecture. We will spend lots of time in the lab learning the actual procedure of injections and IV insertion.